for those who remember. So in the beginning, the HIPAA was, for those who might recall, actually a remaining provision that came from an earlier effort at healthcare reform. HIPAA came out of the Clinton healthcare reform effort of 1994-95. It was a surviving provision from that battle, and the provision was called administrative simplification. The notion was that we spend, that the United States, as Senator Daschle noted yesterday, spends like something like 20% of every healthcare dollar on overhead costs. And so the administrative simplification provisions of HIPAA were meant to reduce those enormous overhead costs. And by the way, in the health reform effort of 1994, the savings were in some ways going to pay to insure the uninsured. But HIPAA was to do this by establishing standards for electronic data interchange relating primarily to claims. And then, as a by the way, the law said that we should also have, if we were going to have an increasingly electronic environment, the law said we should also have standards for security and privacy of health information. And if Congress actually was to enact a privacy law, and if it was unable to do so, the Department of Health and Human Services would publish a regulation relating to privacy. So Congress's deadline was August of 1999. That didn't happen. And so finally in 2002, the Department of Health and Human Services published the HIPAA privacy rule. That rule gives rights to individuals and mechanisms for the exercise of those rights while imposing obligations on covered entities. And covered entities are typically not the people in this room, though all of you work with covered entities. So covered entities are providers of healthcare services, physicians and hospitals and other licensed providers, payers for services, health plans and insurers, and a small group of then claims clearinghouses, which in some ways have morphed into health information exchanges today. So it imposed obligations on those people. It gave rights to individuals. It did not apply, the privacy rule did not apply to organizations other than those covered entities. And it didn't alter the relationships between varying covered entities. So for all of us, and for all of you, between 1999 and 2002, we spent a lot of time interacting with covered entities who had lots of concerns about their new obligations in regard to privacy, the privacy of health information. To emphasize a point here, just to note, the National Institutes of Health provided a guidance in 2003 and said HIPAA applies, the privacy rule applies only to individually identifiable health information held or maintained by a covered entity or its business associate acting for the covered entity. Health information held by anyone other than a covered entity, including an independent researcher, is not protected by the privacy rule. So, pharmaceutical companies, biotech companies, sponsors of clinical research, and CROs in general are not covered entities, nor are they business associates. Business associates work on behalf of a covered entity. Typically, in our situation, it's covered entities who work for us. So physicians and hospitals provide services to pharmaceutical sponsors or CROs. The sponsor or the CRO is not working for the hospital. The hospital is working for the sponsor, and as a result, they're not a business associate, and there are increasingly good reasons, by the way. Some of you may have signed business associate agreements along the way, because it didn't much matter, but there are increasingly good reasons to not do that anymore. Now, along comes ACRO, the stimulus package of 2009. And as it turns out, progress toward electronic health records and electronic health information environment has been slow. In the same way that for our industry, in some ways, progress toward electronic data capture and really electronic systems that capture data once and use it repeatedly has similarly been slow. So ACRO provided $30 billion plus in incentives to providers and hospitals to make meaningful use of electronic health records. We can talk, for those who are interested, we can talk lots about what that $30 billion is going toward. But basically, all of the physicians and hospitals that you deal with now, if they don't already have electronic health records, are likely to buy them, electronic health record systems, are likely to buy them in the next couple of years. ACRO then also directed many changes and additions to the existing privacy regimen, and a new health information privacy framework emerges. Some of us fondly call that HIPAA 2. The reason for you to know about this is the same reason that you needed to know about HIPAA 1, because it means that the covered entities that you deal with are going to have new sets of concerns about privacy issues.